Hi, everyone, and welcome to our Buzz session on August 10th. We're excited to have you all and excited to talk about these projects. So on my screen, Shamir is on the left. So if you will start off and just introduce yourself and tell us the name of your project.
Hello, my name is Shamir Clark. I am working on perinatal drug screening.
Awesome. And then I have Coral.
Hi, my name's Coral. I'm actually in Charlotte, North Carolina, and I am working on early screening of type 2 gestational diabetes in pregnancy.
Very good. And Dirk? Oh, you're muted, Dirk. Dirk, I don't think I can. Oh, there you are. Now go ahead.
There we go. I think I'm unmuted now. Okay. My name is Dirk Maniscalco. I'm doing a tobacco cessation intervention program in an urgent care setting for my program.
Awesome. And Elizabeth? You were also muted.
Hi, I'm Lizzie Brink. I'm a midwife based out of Tacoma, Washington, and I'm doing a project on essentially bringing nitrous oxide to our labor and delivery units to increase maternal satisfaction with childbirth.
Cool. And Jennifer?
Hi, I'm Jennifer. I'm doing a project on postpartum hemorrhage in Hammond, Louisiana.
Very good. And then Cara, you want to introduce yourself? Dr. Jefferson.
Good. I'm Dr. Jefferson. I am one of the newest course faculty members. I got my DNP from Frontier, and I'm excited to be with y'all tonight.
And for those who don't know me, I'm Nisa Meyer. I'm also one of the faculty in this course, and I am very excited to be with you. Buzz sessions are my favorite. I like the part where we try to figure out how we're going to make these projects come together. I like ideas more than the real thing sometimes. So, all right. So let's start off. Does anyone want to start off by kind of presenting their project, like present your GAP patient tracer, that kind of thing, just really quickly? Just kind of give us the tell us how did you find out there's a problem? What is the problem? And then we'll start off with our ARAMP.
If you want me to. There
Go
you
ahead,
go first
Coral.
if you want me to. Okay. So my project is early screening of really probably identifying type 2 diabetes, because they're probably going to end up type 2 after postpartum. So trying to prevent that. But what I was noticing is I work with 6 other providers, and we did not have any type of system for really identifying any risk factors. I mean, yes and no, but it just wasn't on a consistent basis. So even, with flagging their BMI or, anyway, so all those risk factors, we didn't really have a good way of screening them at our new OB sessions. So identifying that problem, it's actually one of the Medicaid pathways that's very kind of runs parallel with their obesity. So after talking with our social worker that comes in from our county, she and I, and talking with other providers, and anyways, some of the quality measures that's up a little bit higher in our system, I decided to focus on the early gestational screenings. So basically what I'm trying to do is I've identified that if we do identify those risk factors, we do a fairly decent job of testing, but then we don't always do the same thing. So somebody might do a 1 hour OGTT or glucose tolerance test, or some of them will do a hemoglobin A1C, and it kind of just varies. Who knows what from provider to provider that we would do. So basically, that is the foundation of my project. And then identifying those factors, I mean, I could go into detail, but I found, communication errors, and as far as like our staff, just not really flagging those, I guess, when they're taking the history. So that's kind of the basis of my project. Hopefully that's what you're looking for.
Yeah, so talk about your gap analysis specifically. What did you find were the gaps in practice?
So the gaps in practice were the fact of the risk factors not being identified. So, obviously we always take a BMI, but regardless, so we always do a BMI, but we might not find out that, that they had over a 9-pound baby, or we might not, find out that they had gestational diabetes in their last pregnancy, or, always those risk factors that they might have. And, sometimes we don't even look at their BMI. I mean, if it's really high, then that might flag us, but in society, we've just kind of grown accustomed to patients being overweight, and in pregnancy, it's kind of a hard thing to identify too, and have that conversation because it's uncomfortable. So, and then obviously too, the screening measures. So what would we do even if we didn't identify those risk factors? Would we do the hemoglobin A1C? Would we do the 1-hour glucose tolerance test? So that's what I found in my, as far as doing like the chart audits, and then the gap analysis, and then what was best measure versus what we're doing. And that was what I found in guidelines, is that they actually recommend the 1-hour glucose tolerance test. So instead of the hemoglobin A1C in early screening, and we're not all doing that either. So trying to get on the same page is really what my project's all about too.
Okay, great. So what I wanted everybody to see is how those early assignments, are you guys getting feedback?
Yeah.
I am too. Let's see, so what I found is that those, what I wanted everybody to see is how those early assignments really helped to inform the project as a whole. That your gap analysis helped you to see that the very best screening was to do the early 1 hour, right? Instead of to do a hemoglobin A1C or to have varying levels of screening. Did everybody find those kinds of things in their gap analysis? So the problem that you were looking for was there, but you thought, you sort of knew there was a problem.
So I knew that there was a problem, not necessarily that it was, outwardly there, but after I got through some of the charts, it was easier to see where the gap was. Like we might have been screening for half of, the things, like instead of screening alcohol, tobacco, and drugs, we would only be screening for just tobacco, or, it all wasn't documented as a part of the screening.
Yeah, definitely. So your gap analysis really showed you the thing that you thought, that that we needed to do more complete screening. Did everybody find those early assignments to be useful? Did they help you to really see what you needed to do differently? What about the patient tracer assignments? Did anybody find that it really informed their decision making moving forward?
I think that it definitely did help me with my decision making, but honestly, I kind of had a hard. I see hindsight being 2020, I guess, on those assignments. After I, got a lot of feedback and everything like that. Hindsight being 2020, I saw it then. I don't know, when I was doing it, it kind of felt like a mumble jumbled mess, I think, but. Afterwards, hindsight being 2020, like I said, and talking to faculty and everything, that helped.
Good, yeah. Thinking about this process is easy.
That's for sure.
I think with my patient tracer, the way that I did it, instead of doing yeses and nos, I did checks and X's, or yeses and nos, I did checks and X's. So it provided a little bit more of a visual of, where we were missing. There was a lot of red X's in there, so I was able to kind of identify the areas that we were really lacking just based on looking at the chart, and seeing all those X's, or going across the line with my specific patient. So like some of the things that I used were, whether the patient was being screened for drug use, whether they were being screened for alcohol, whether they were being screened for tobacco. And I was able to see, maybe 20% were screened for drug use, but only 10% were screened for alcohol. So it was a nice way to kind of pick out those areas that we might be lacking, or the questions that the medical assistants are not asking. Maybe they're just asking about drug use, but they're not, incorporating the other things. So it was a good way to establish that deficit with the questions that the medical assistants were asking, and also where we needed to improve on screening those patients.
Yeah, definitely. I find your project to be really interesting. I totally intend to watch how it goes and learn from it for my own clinic. So,
thanks.
You're already influencing someone.
Thanks.
All right, so let's talk a little bit about the measures. Whenever we talk about measures, sometimes in these sessions, people are a little bit like sort of bug-eyed about how to do this and what this looks like. So I want to talk through them like A, B, C, and D, but then have us sort of share our measures worksheets a little bit and talk about what we've got. Yes. So the A measure is our staff engagement, right? Mm-hmm. So everybody's had a chance to kind of think about staff engagement and what does that mean and what does that look like. So with the staff engagement, what we're looking at is getting the people on the team to be excited about and ready to participate in the project. So what I'm learning from watching my students over the last couple of terms is that this is actually probably the most important ramp. I would say this is the ramp that determines whether the project is successful or not. And a lot of the time, this ramp's a little bit underdeveloped. This can be a ramp where we just say, well, we're going to have a meeting because, we already did all the gap analysis and all the literature review, and we know what's right. So all of the people on our team should just do it because we told them to. Mm-hmm. But that doesn't often work. So we'll talk about ways, some strategies, some things that we can do to kind of get our teams really engaged. Does anybody have a team engagement ramp that they're real excited about? Nobody has one they want to share?
I feel like that's the hardest one for me. I don't know why, but it's the one that always has the blank spaces. I feel like I just draw a blank when it comes, especially because our team is so disjointed right now. So
it means you need it more than anyone, huh?
Yeah.
I have one. I don't know if it's a really but when I first started researching all this stuff, I thought, oh, it has to be all these evidence-based articles and all this other stuff, and it does. But I kind of went down to the basics because I have to remember who my team is and, what they're going to be interested in. They're not going to be, you want to share the facts and everything, but I started thinking about it and I was like, oh, I love to play Family Feud. That would be fun. And it kind of incorporates a team thing too. So I don't know. I started thinking about those types of things and trying to bring it more down to that a little bit lower level than I was trying to make it as.
Yeah, I love what you said about having to know your team, because each of you guys know your own environment, right? And you know the people in your team. So some of you are going to have 90-person teams in major university medical centers where you're going to need to really present the facts and present them to large numbers of people without messing around or wasting anybody's time. And some of you are going to have a team of 6 people who generally have no interest in doing what you're asking them to do, and they're totally going to respond to a sticker chart. Maybe with some rewards. One of my students had some X-rated coloring books as the reward. Let me tell you, it turned her project around. It was life-changing. So you're just going to have to know your team and what kinds of things might really work for them. Anybody who hasn't really talked to us about their project yet want to present their measures worksheet and talk about their team engagement?
Oh, sure, I'll go. So as far as my project, of course, it's a tobacco cessation program in an urgent care setting. Of course, urgent care is not the most common place, of course, where you see people actually doing an intervention, of course, or, and a lot of the people feel like, oh yeah, that's not my job. That's the primary care's job. But of course, the big thing is, of course, the literature says, yeah, we should be doing it at every patient engagement. And some patients, they may not come back for, 2 or 3 years, especially if they're young and they may be smokers. So we're missing those opportunities. With my project, I guess the biggest gap issues, of course, that came up was basically that, the majority of the screening is occurring. And of course, that's because the medical systems are doing it as part of the vitals. So they're asking every patient if they're smokers. But the problem after that is that no one's doing anything about it. No one's counseling the patients. No one's telling the patients to quit. No one's assessing for willingness to quit. And of course, in my chart audit, of course, with that, it showed basically like, of the charts, only like, 10% of them actually had where somebody actually did counseling or charted counseling. And of course, all the rest of the charts, had no mention of anything about their smoking history, nothing other than basically the MA checked the button saying, yeah, they're a smoker. So then, of course, that was the one issue, which was, of course, showing the gap, of course. And we already everyone kind of knew in our clinic, yeah, that no one's kind of really doing this. And so then, the other option was trying to figure out, of course, where the problems were coming from. And of course, part of that was going to the providers. And I did like a survey monkey through our entire system of all the providers, just of how they felt. And of course, out of like 59% of all the providers, they stated that they weren't up to date on the current body of knowledge or evidence. And the majority of them did not feel comfortable even treating because they weren't familiar with basically what the evidence was, or what drugs to be using, or basically even how to be approaching the patients and how to be engaging them, or they feel that, they're going to offend the patient or they're going to upset them just because they don't know how to engage the patient, and the different types of interviewing techniques, of course, or things that you can do, or just, simply asking the patient, are you interested in quitting, as opposed to telling the patient you shouldn't quit. And of course, turning off the conversation. So of course, the biggest thing with my project was figuring that out. And of course, measures on this, that gets a little bit more complicated.
Do you want to share your measures worksheet with us?
So my measures worksheet, where's that here?
So if
my measures worksheet. I don't know if you can see it. I don't know how to share it on the system.
If you've got it on your computer, then on the top left, there's a green button called Screen Share.
Oh, let me see here. Well, the problem is it's on, I have 2 computers sitting here, and one of them has all my work on it, and the other one I'm using to talk to everyone here, so I don't know if I can.
Okay, that's no problem. Why don't you read us your
read us. So as far as like my measurements in my my measurement worksheet. So of course my first ramp, of course, my team engagement ramp. So of course for this one, of course, I'm trying to conduct an education and service for the providers as a staff meeting on the current body of evidence, basically trying to make them all more comfortable on what the current strategies are. And basically, with this, of course, going back to that thing with, of course, there being only 59%, I'm saying, or 59% of people saying they don't feel comfortable. And then, of course, for like my outcome measure on this ramp, basically, my goal or outcome measure is clinicians' knowledge will be increased and feel confident in tobacco cessation interventions methodology, and 80% of participants will report increased comfort carrying out interventions surveys. So that's my first ramp, is of course, just more so engaging the providers to feel comfortable, so they will be able to conduct it and giving them the tools they need for basically of how they should be approaching it. And of course, in this ramp, of course, I plan on making like cards, of course, in the provider work areas with, the current medications listed, all the risk factors for those medications, contraindications for those medications. And I'm also, on that side of it, developing templates within our EHR for them to be able to put in that have all the different, components of counseling, and of course the 5 A's of intervention, and of course the different type of treatments, or basically if they're referring the patient. So a lot of it's just more, urgent care is one of those places, you don't have a lot of time. So it's, of course, that's the type of thing, is getting them to buy in for, the limited time you have. But of course, even a few 2 or 3 minute conversation, and all the data and the literature says is meaningful and useful. So of course, the goal I get for everyone is at least to get basically them to, one, make sure we've assessed all the patients, that they've all been screened. If they're screened positive, at least, assessing their willingness to quit. And then of course, giving them counseling. Okay, here's what you can do. Here's how to help the patient. And then, of course, if they're going to treat, or basically instead of treat, that they refer to either quit line or to refer them to basically their primary care and have them set up an appointment at that visit to at least carry out that, aspect of the ramp. And then, of course, for my
So Dirk's project is a real classic model. Does anyone know what this model is?
Espert?
Yes. Yes, makes me so happy that you said that. Yeah, it's an Espert model, and depending, I mean, I don't know all of your projects deeply right now, but a lot of you probably have Espert projects, and they're really fantastic, right? So we're looking at screening, brief intervention, and referral to treatment. So it's important to point out that referral and treatment, it might be, like you said, Dirk, referring out to primary care or somewhere like that. But sometimes that referral can actually just mean that you follow them up yourself, that you initiate the treatment and that you are going to follow them up one more time. Now, I actually have never worked in urgent care. I have no idea if that would probably be a ridiculous idea in urgent care, huh? Doing a follow-up.
No, it really wouldn't. It's going to be, he's going to have other challenges because I work in urgent care. Your project has a lot. You were going with teamwork, and then I heard every single ramp when you went over what you're going to do with teamwork. And I commend you because what you're trying to do is make your providers' lives easier, but you can't put all of that in your teamwork ramp.
Yeah, and that's where it's having a difficulty. It's like all these ramps start crossing over each other, and they start each other, unfortunately, because they all have components of team and patient engagement in one, and the processes are all kind of coming together is what I'm finding.
You said something about providers being comfortable. I wrote that down. When you said that, you were looking at that as one of your outcomes. You had a really good outcome of what you wanted to do. How did you operationalize that definition? Like, what were you planning to do to assess their comfort level?
So for the start of this, of course, what was used was that a survey, of course, surveyed all the providers and how they felt in their comfort levels and basically with treatment. So, of course, after the fact and after we do the basically education and service, which I'm going to do at one of our staff meetings, that's like right at the beginning of basically the implementation, is to assess at that point after and use another survey and to get them to respond of how they feel about it. And then, of course, once they get into it and start doing it in the practice, then reassess at that point in time, as basically we're going through and keep doing surveys throughout the period and just kind of seeing if their comfort level changes from beginning to end, or of course they feel like, yeah, I'm able to carry this out. I feel comfortable with, engaging the patients on the subject or not. And it's really hard, because it's really hard to quantify this and where you actually sit there and say, yeah, this is, I want to do this and I feel comfortable now. And a lot of times the problem is, of course, you have a lot of different drugs and medications, something like Chantix. A lot of people don't like that drug. A lot of people feel uncomfortable with it because they don't prescribe it a lot, especially urgent care providers. We don't do with those drugs. Some people have more comfort with, of course, like Wellbutrin, but they have, a lot of comfort, of course, with nicotine. But when you start going that other direction, they're all kind of like, well, I'll probably engage the patient and I'll probably refer the patient, but, I don't know if I'm going to treat the patient. And the lot of problem with our clinic is that, there's not any processes set in place. There's not any tools. There's no community resources. There's no templates in the system for counseling or doing any of these things. So there's a lot of pieces to the puzzle that are just missing. It's, trying to put all those pieces together, which is what I'm finding. And I'm like, oh my, I have 4 ramps, but of course there's many more things that need to be done. And that's where it gets a little more complicated. So I don't know, do you want me to go into my other ramps or my patient ramp? And
no, so I think your staff ramp makes a lot of sense to me. I think you really have a good idea there. I think you honestly have it nailed down a lot better than a lot of people. What I wanted to point out is that you're going to start off with this education, right? And nearly all of you guys will. You're going to start off with some kind of educational meeting at the very beginning. But you can't just do one educational meeting. And your staff will be really bored if you just do 4 educational meetings. Although you might find that you do 4 educational meetings. But what you'll do is start off with an educational meeting, and then you're going to do something every week to keep people engaged and keep them thinking about your project, keep them involved in your project. And some of those ideas you're going to really have kind of lined out now. You're going to have done some research so you know what those ideas might be. And some of them you may kind of adapt as you go along, because you'll find that people are less, you feel like maybe people need something fun, or maybe people need more information. Some of the things that you talked about as staff engagement, you talked about doing the cards for the providers with the information on them and stuff. Those may be things that really fit better in other ramps, and they may even be the things that you ramp up. So I guess let me just go over that really quickly, because I didn't start off there, and it might help you guys out for me to do that. So the 4 ramps are staff engagement, patient engagement, and then your 2 process changes, right? Your 2 sort of the meat of the project, the things that you wanted to change. But every cycle, and the cycles are every 2 weeks, you're going to be doing all 4 ramps at the very first day of the project. And then every 2 weeks, you're going to be making changes. And honestly, you may make changes faster than that. As you're looking at your data every 3 to 5 days, you may find like, oh my goodness, this is not even working. I need to make some changes right away. But as you're making those changes, you may find that you need to kind of do different things to ramp those up. So I love, Dirk, that you have all those ideas. And it may be that you start off with a lot of those things in place as part of one ramp or another. Or it may be that you start off where you start, and then you find that, the providers really do need that information. They really do need a card to help them figure out exactly what to prescribe, or they really do need the contraindications listed. And so some of those things are the things you're going to make up on the fly as you figure out why people are uncomfortable, or what is keeping people from prescribing regularly. And so it's good to have those ideas, but you may not end up doing them exactly as you think right now, which is fine. That's good, actually. And I would love for you to be over-prepared with more things than you need. So I feel really good about your staff engagement ramp. I feel like you've got that lined out really well. So I'm glad you stepped up with staff engagement. Does everyone kind of get why Dirk's staff engagement works? Like the way that he's going to be doing the education to start with, but then he's going to measure, his outcome is to measure consistently how comfortable is his staff with prescribing and with doing this process. Cool. Okay. That's what I like to see. So let's move forward then into the patient engagement ramp. So in an SBIRT project, this is often the brief intervention. So for those of you who are doing an SBIRT project, think about the patient engagement as being your brief intervention part. Is there anybody that would like to pull up their measures worksheet and kind of show us their patient engagement?
Mine's not finalized, but I'll show it.
Sounds good.
Let's see. Okay. So this is my measurement worksheet, and can y'all see it all?
You know what? Can you make the measurement worksheet bigger?
Let's see.
There. Yeah, I feel like that's bigger.
Okay. I am planning on going to my site tomorrow to see if this is going to be a viable ramp or not to engage the patients with. Because I'm doing postpartum hemorrhage, and addressing anemia is an important part of that. I was looking at creating some type of tool or figuring out a way to address anemia with the patients that present to the labor and delivery triage area. And then educating the patients on iron-rich foods and why it's important to take their iron supplements that they're prescribed. A lot of our patients say that they're just not taking it. We don't ever investigate why they're not taking it, or talk to them any further than just a simple medication assessment whenever they present for whatever their complaint is, whether it's rule out labor or rule out rupture of membranes, or they've been feeling lightheaded or dizzy. So I need to get the data that supports that this is a good idea. And if it's a good idea, I'm going to try to create some type of assessment to include in the triage to talk to the patients about anemia, and then some type of education to provide with them and to provide them with before they leave triage, and then also maybe try to engage them or convince them that it's a good idea to take their iron supplements. Or if they don't have an iron supplement prescribed and they have anemia documented on their prenatal record, maybe talk to the providers and see if they will prescribe an iron supplement for the patient for when they go home.
Jennifer, are you using a toolkit?
I'm using the CMQCC toolkit, but I've not I don't see anything in there specifically related to anemia aside from the fact that it's something that we need to be looking at. And I also was using the WHO, the World Health Organization guideline.
So the patient engagement method or the thing that flows most naturally from the CMQCC as far as patient engagement is the kind of process around traumatic birth and debriefing traumatic birth. But I think what we talked about is that even if we include all patients with traumatic birth, that we may not end up with very many in kind of a moderate volume site. Mm-hmm. And that may not be the volume that we need to really have enough built into that ramp. So what I wanted to talk about with yours is the outcome. So read me your outcome measure again.
Increased number of patients with anemia that have a current prescription for iron by 25%.
Can you put it back up again?
Yes.
Just so we can see.
Screen share.
So for the rest of you guys in this session who are kind of listening and thinking about your own patient engagement ramps, what do you think about your outcome being increasing the number of patients that have a prescription, patients with anemia that have a prescription for iron? Do you guys have any suggestions for that?
Is this more related to a process measure? Like a process change?
So the outcome, because we can prescribe all day, but it just depends on, is the patient following, what's the reason they're not taking their iron supplements, exploring that, but then the outcome should be.
What is our goal? Like, what do we really want from these patients? Do we want them to have a prescription for iron, or what do we really want from them?
You want their H&H to return to baseline. Right. So you, instead of doing prescriptions, you would want to focus on those patients that have H&Hs, at 6 weeks postpartum that have returned to a normal level, I would think, versus the amount of prescriptions that you're providing to patients.
Okay.
So I think Jennifer was thinking of doing this like in the antepartum period, and you were saying just patients that present to triage, not clinic patients, because I think your project is not really being implemented in the clinic. Is that right, Jennifer?
Yes.
Okay. So patients that present to triage anytime in the antepartum period who are anemic and are not taking iron for whatever reason, whether they were prescribed it or not prescribed it. So as I'm listening to that, I'm thinking that our goal is that we want these patients to actually take their iron, but the way to measure that would be to go to their house and watch them take it. So that seems problematic. So we could maybe think about like patients agreeing to take their iron, or patients, what are we thinking of that we would want these patients, that we could do in a hospital stay where this patient would sort of change their behavior moving forward?
Maybe discuss with them, during their stay, bring that iron information to them and maybe discuss with them, or have them discuss with you the importance of taking their iron, something to engage them, I think, a little bit without going to that, I don't know.
Right. So I'm wondering, Jennifer, about the creation of a tool that would help to explore why patients were not taking their iron, and were any of those things fixable? Because there are many different iron preparations out there now, right? It's not just ferrous sulfate. So maybe there are other things that people could take that wouldn't upset their stomach. Or maybe people don't like taking it because they don't think it's important. Or maybe nobody has ever talked to them about the foods they could eat that would increase their iron levels in their blood. Or so have you guys seen, I'm sure in the course you've seen shared decision-making tools. I'm sure you've come upon them in your, there are in the course. Is anyone using a shared decision-making tool that they really like?
I guess with my project, the hard time I was finding is that there's not a lot of good shared decision making for basically this topic. Like the only one that was like utilized as an actual shared decision making tool I found was actually one for basically smoking cessation for surgery patients, for people going into surgery, and it's only like temporary cessation. So I had to kind of design my own based off of some vague ones from the American Academy of Family Physicians, mixed with basically the University of Colorado's Ann Schuetz toolkit, and then kind of developed one myself. Because I kind of, as far as the tool itself, I developed a sheet, and what my plan is to use the sheet to have like the medical assistants when they're rooming the patients and they've been identified as smokers to start filling out the sheet. And then let me see if I can, I uploaded it from one to the other. When you say the green thing to share
it's
something.
on the left. On the left, it's a white arrow in a green box.
Okay. Maybe if I can do this, I can show you the tool that I'm kind of. So this is the tool that I created, which is basically, it's kind of two tools combined into one. So the patient will kind of fill it out, and it kind of gives, like, to open up the conversation where the provider comes in to kind of engage the patient to identify like reasons why the patient continues to smoke, and then reasons basically why the patient wants to actually stop smoking. And then the bottom of it would basically be like, you know, setting a quit date or like a goal for it, so they can just kind of engage with the patient. I don't know. Can you see this?
Yes.
Okay. So it's kind of, and I was having a hard time with this just because it was very difficult to find tools that actually would implement as part of my project that would work well. So a lot of it's just kind of working with other tools and kind of combining to something to engage them. And so I'm hoping this is going to be something that's going to be helpful and that's for my patient engagement RAM, that tool.
I really like how you had the two, like the columns of, you know, why am I smoking or why am I using tobacco, and then what motivates me to change. And I was just listening to a podcast today about how, as providers, they were saying that, you know, you should never tell someone to stop smoking. Like, that's the worst thing you can do. But, you know, rather explore, you know, why do you smoke? Like, there's a reason. Mm-hmm. So I love that that was forefront, so that they can help to determine that for themselves.
It's almost like you put that motivational interview.
Yeah.
I think it's awesome.
Yeah.
Yeah, and that's where I was trying to go with it, is the motivational interviewing side of this. Is it's like, you know, a lot of people, I mean, you know, like, you know, if you look at a lot of the smoking cessation campaigns, they're all very negatively focused, and none of them are really positive focused whatsoever. And that's, you know, a big problem. And I think that's one of the big failures, of course, when you look at a lot of the literature of why a lot of programs have failed, is because they're so negatively based. So of course, trying to get a tool that engages them and can focus on the positive sides of why we might be doing this, you know, is, I think, probably maybe a better way to help engage my patients and to bring them in to get their buy-in to think, oh yeah, okay, yeah, this is a good idea. And of course that they're going to actually listen to you. Because many times they just they turn off as soon as you say anything about you need to quit smoking. So, you know, a different approach, you know what I'm saying, for the motivational interview is exactly kind of the direction that I was going with a lot of this, to try to bring them in and get their buy-in on this.
Yeah, so Jennifer, when I think about your project, I think you are almost definitely going to have to write some kind of tool yourself. Mm-hmm. It's possible that it exists, but I think it doesn't. So, so then what you're going to do is really think about all of these principles. So maybe do a little reading about motivational interviewing. It's going to be hard for you to count on whichever nurse is on staff to do a really great motivational interview. But if you put a lot of the scripting into the shared decision-making tool or the decision aid, then you can leave a lot of blanks for patients, so that the questions might say things like, you know, like maybe it's something that every patient in triage just receives. Like, are you anemic? Yes or no. And so then the nurse has to answer yes or no. If it's no, then, you know, we move on. If it's yes, then maybe from that point, the patient has to fill it out herself. Like, have I been prescribed iron? Yes. Am I taking it? Sometimes. Why? Does it hurt my stomach? Do I feel like I don't really need to take an extra pill? Am I tired of taking pills? Like all the things that you've heard people say. It's too big. Whatever. All the stuff. And then you can kind of help, you know, then the decision aid might sort of follow down into a tree where you can figure out like, what are the things that we can do from this point once we have this information? And maybe the only thing that happens is that the nurse shares that information with the provider. Maybe the nurse says, hey, just so you know, she's not taking her iron because it hurts her stomach. And then the provider can make that decision. Or, you know, you'll really have to think that through. One of the things about these projects is that they take, at least in this course, in PC 730, you're going to spend 10 times the amount of time thinking that you're going to spend doing. So every minute of every day while you are, you know, walking the dog and washing dishes, be thinking about this. Like, how would this work? Well, can I ask the nurses to do that? What will they say? So all of that, the decision aid, all that stuff would be something, that would be the process, right? That'd be how we address this with the patients. And then how do you feel about your outcome? Like, what do you think you would want your real outcome to be?
Maybe the outcome could be like the number of patients who would agree to start taking their supplements, or the number of, I wanted to say the number of patients presenting to labor and delivery with an H&H, because we do draw labs on everybody that presents. But I don't know that we would be reaching everybody in a timely fashion, like for them to start taking their iron and for that to make a difference.
Yeah, so I don't think you have to operationalize it quite yet. Let's just kind of think through what we really want from people. If these are people who are presenting to triage and they're going to go back home, then I think what you said there is really good. We would like them to want to take their iron. We'd like them to at least verbalize that they have a plan to start taking their supplement. And, you know, however that is, whether that means we need to ask the provider to prescribe a different supplement, whether that means that they have a plan to start eating all these iron-rich foods that you've told them about, or, you know, whatever, but that they now sort of feel in control of this. They know how important this is. They know that it's a risk factor for postpartum hemorrhage. Then they can decide, yes, I feel really strongly about this, and I think that I will make sure that I get extra iron into my body, and this is the method that I will choose to do it. So as you're writing that decision aid, you should write in a question there that really helps you to measure whether this is working. You know, so maybe you write, maybe it's a blank for the patient, like my plan is, or something, and you figure out, you know, how many patients write in a viable plan for taking their iron. I'm just sort of throwing things out there. You'll have to do a lot more thinking about this than what I'm doing on the spot, but you'll figure something out. Does anybody have any questions about patient engagement, about how we did that? I would recommend using a tool for your patient engagement. You're going to want some kind of piece of paper because patient engagement is tricky. And if you're expecting other providers and other people in your environment, other team members to do that patient engagement, you're going to want to give them a guide on how to do it.
I think that's where I'm sorry, Coral. Go ahead.
Out go in how to, I mean, I know we were how to manage time. I can just get examples yes, of other people's out measure.
Hey, Coral, I'm kind of losing you. Is she cutting in and out for anybody else?
Yeah.
Okay. Yeah, I'm only able to hear a little bit of what you're saying, not consistently enough that I'm hearing all the words.
I'm connected all the way. Is it better?
I think it is.
Is it better? Okay. Measure is where if anybody has any good examples. No good examples? No, it's not good?
It works for just a little bit and then not. Do you have earbuds or anything you can plug in?
Yeah, or I can get closer to my modem. You guys can go ahead.
Okay, Shamir, you were starting to say something.
I kind of
Patient engagement. We were talking about tools.
Well, so I'm doing a SBIRT model with perinatal drug screening, and my patient engagement is going to be the brief intervention that I and the other providers will implement with our patients that screen positive for any of the substances, alcohol, tobacco, or drug use. And, trying to establish, I guess I just wanted to confirm, for each I need to have, say, 4 or different types of brief intervention in case one doesn't work. Does that make sense?
Are you thinking like for the 4 different cycles, like if one of your brief interventions really didn't work? You know, unfortunately, it's really hard to plan ahead quite like that and say like, oh, here's what I'm going to do for cycle 1 and cycle 2 and cycle 3. What I would do is pick the thing that you think will really work the best, and let's sort of go all in on that and see what happens. And if that doesn't work, rather than tossing that tool and getting a different one, you'll probably just tweak it in some way.
Okay.
And so there's probably smaller changes that you'll be interested in making. Occasionally I see someone just like they get into their clinical site and their whole team is like, this tool is stupid and we don't want to use it. And if that happens, sure, you grab a different one and you try to figure it out real quick. But hopefully you've been able to sort of build a coalition of support and get all the important players in on this project a little bit in advance, so everyone's got a little buy-in before you really get started. So hopefully they don't just completely hate it, although it's maybe been known to happen.
Okay. I was just curious about that, because it's really hard finding tools that you like. So I was like, I hope I don't need, to change it after if it doesn't, 4 different times. So I just wanted to make sure that.
For the students that I've had, nobody's really had to completely change their tool. What most of them find is that they start off with these really long tools like that have 10 plus questions. And no patient wants to sit there and answer that. So what happens is they usually modify it over time, but they start off with it because they're convinced that it's going to work. So you only know that when you go through it.
Right. And the volume of patients that we see, we only have a certain amount of time with those patients. So, the tool needs to be something that is quick to implement, but also, the intervention, my process 2 and process 1 needs to be something that can be done because that's going to be my biggest complaint. I don't have time to do this. I have 20 other patients to see. So trying to implement something that, everyone can get on board with without having them totally bark at me for even trying to do it in the clinic, So.
Yeah, definitely. I think you're on the right track there. It really helps when you're one of the clinicians on the team yourself. So as well as anybody how hard this is going to be, how much of a pain it is going to be to take time to do this. At the same time, it may speed things up. And I think in a lot of practices, they find that it speeds things up because when you find that this is a problem you're running into regularly where you as the provider who wants to do the right thing is having to make up all this information on the spot every time you try to handle it. It's going to give people, a 2 or 4 or 5 minute, like, this is the thing that you do when that happens. And you just, it becomes really automatic and really easy. That's the goal, is that we make something so hardwired in that it actually makes people's lives easier, not harder. So is everyone feeling kind of good about patient engagement? They sort of know what they want to do and how that's going to move forward. Cool. Okay, so process changes. Process changes are fun. I mean, they're the thing that you really noticed first, right? You looked around at your environment and you thought, we could really use this or we could really use that. So process changes are great. You're going to name your process changes. You're going to name those ramps. So they might be a screen everyone ramp, or it might be a quantitative blood loss ramp, something like that. So you're going to name those ramps. Does anybody have like Lizzie, we haven't seen any of your stuff. Do you want to pop up your measures worksheet and we can look at your C process?
Sure. I don't have it in digital format right now, but I've got it right in front of me.
Okay.
That can kind of just talk through a little bit, if that's okay.
Sure. Why don't you go ahead and read us the process?
So the process, so process number 1 is going to be essentially, well, screening our patients to see if they meet appropriateness for nitrous. And so this is my nitrous ramp. And so my process measure would be using a built-in checklist in like the labor Epic order set to see, is this an appropriate thing to be offering this patient?
So is every patient going to have the checklist done?
So, yes.
Yeah, and that'd be awesome if
Ideally,
everyone did.
Ideally, because it would be part of the, I mean, that's the goal, because part of the labor order set. And so it's one of those things that you don't, as all providers, you just kind of click through that. And, I mean, the goal, I don't have 100, like my goal is not to have 100% screen, because I don't think that's feasible or at this time. At least for my first round of intervention. But ideally, I want that to be a trigger point for providers going through the order sets to ask themselves, would this be appropriate?
Is that already on your order set?
No, but it will be.
Do you feel 100% confident that it will be by the start of this project?
So, no, but one day it will be. So
yeah.
So things, and this is, I'm experiencing firsthand, a large organization getting a policy pushed through, and it's been a really great learning experience. But it's taken a long, long time. And
so one of the things we talk about a lot in this project, we talk about this not necessarily being policy change, but being more of a pilot project.
Right.
So if you talk to the staff on the unit and talk to the, usually it's nurse managers, those kinds of people who are real plugged into hospital culture and know like what all the rules have to be.
Right.
You could talk to them about doing this as a pilot project, or you could find some way to make absolutely sure that, but you're going to have some kind of mechanism for getting this done, like by the first day of the term. Because if you can't get it done like by the first day of the term, you really can't implement. You can't have, you can't sort of have that worked into your time frame, because what will happen is that they will decide that they can't possibly approve this order set until the next order set meeting, and that's going to happen in 4 weeks. And then when that happens, they'll say they really didn't have enough information. And it doesn't always play out. So if you think like you've got, what do we have left in this term? 6-ish weeks left in this term?
4.
Oh my gosh.
I think we're week 6.
It's 12 weeks in the term, right?
Well,
it's 11 weeks in the term.
11 weeks, and then 1 week in between. Okay.
Yeah.
So not a lot of weeks left. If you feel like you can get that checklist built into Epic right now, people can use it or not use it. Who cares, right? If they start using it right now or don't start using it right now. But if you have all the infrastructure in place before the term starts, then I think you can roll with that. But if you don't have it in place before the term starts, you need a backup plan that the hospital will accept. So whether that is we're going to use a paper checklist for this, or we're going to do paper orders for the nitrous or whatever, really talk to them aggressively about it now. Because if it's not going to happen, then, I mean, the whole project will derail and you won't be able to do it at all.
Correct. We had talked at the very beginning of the term kind of about, working this out in a big scheme of things. I guess maybe we can talk about this later as well. But that the project, the trajectory of the project might not match exactly what's happening in real life at that moment. So we had talked about that. How do you feel about that now?
Well, I mean, I think you can't write things on paper. Obviously, they aren't happening in real life. But I think there are ways for things to, as long as there's a pathway forward. Like if you don't have it written on the computer yet and there's a pathway forward, then that's cool.
Yeah.
It doesn't have to all be like exactly how you want it to be finally, but it has to be able to start. And hospitals sometimes throw up these random roadblocks. And so you just make sure you've got everybody on board right now, that everybody, like if you had to start the project tomorrow, you have some kind of mechanism for doing that.
Yes, and so I mean, like we've got one of our smaller hospitals is taking on the pilot project, and like we're getting, I mean, everything approved through the different committees and collaboratives and things like that. So I mean, there is a plan moving forward.
Okay, who is your continuity faculty?
Assigned in the beginning of this term, right?
Yeah.
Diana. Dr.
Okay.
Doss.
Have you guys talked about it at all?
No.
Okay. She's probably the very best person to talk to because she's been through so many of these projects now that she will be able to see pitfalls further out than I can. So yeah, I would recommend just giving her a call and talking through that a little bit and making sure, because it'd be so much better to plan ahead now and have a system for how you're going to, jump around this, instead of something just, a barricade coming up and not really knowing what we're going to do about it. But so let's go back to the idea here. The idea is that every patient has a checklist completed. And so that would be the contraindications for nitrous sort of checked off, right? Like the things that, and what kind of things do you have on that list?
So those are things like a B12, B12 deficiency, abnormal air containing cavities, respiratory distress, head trauma, impaired consciousness, intoxication. I could go on.
Okay. So it'll be a pretty easy checklist to run through, even if you had to create it on paper or something like that.
Easy.
Cool. Okay. And then what would your outcome measure be? Like, what would your process and outcome on that screen everyone kind of ramp look like? Like, do you have that written down?
So the outcome would be how many people were actually so the process, the process measure would be who all was screened for appropriateness, and then the outcome would be how many people were actually offered nitrous in labor.
Okay, like both deemed appropriate and offered.
Right. Yeah.
Okay.
But I don't think an outcome, I don't think the outcome needs to be if they accepted use necessarily, because that's not my goal to push this on everybody, but at least that it was made available to them.
Yes. I want you guys all to know that it's totally okay to measure more things than what we're requiring you to measure. So like in your project, I would just be super interested to know how many people end up using nitrous. And you may not even ever use that data for anything, but I think for yourself, you'll want to know it. So you can just always have a separate run chart that's just like, hey, how many people actually use nitrous or whatever.
Yeah, easy.
Awesome. Okay, one more process. Anybody else want to share another process and outcome? Like another ramp is what I meant to say.
I'm doing screening for my process one. So it's screening for perinatal drug use. I will be using a specific tool to do that. And it will require putting a couple different tools together since I'm doing drug, alcohol, and tobacco. So kind of combining those into one tool one short tool to be able to screen for drug, alcohol, and tobacco use. My process measure is going to look at the % of patients properly screened for drug use. Because right now, the way we're screening is that one closed question, are you using drugs or are you using alcohol? Have you used tobacco? It doesn't assess any history. It doesn't assess, right now we're not assessing any of the other, whether family or partner use in the clinic. So those 3 questions are asked, and a lot of times they're not all asked at the same time, or one is asked in the other 2. So properly screening was important for the process measure. and that would include screening and identifying those risk factors. So the outcome would be looking at the number of screens that were completed. So the, what did I do? So the number, I wanted to see how many people were actually screened properly. One of the things that I wasn't sure of is because we're screening for 3 separate type of substances, whether I needed to have 3 separate outcome measures. Does that make sense?
Sure. Yeah, I see what you're saying. I can see this both ways, but I think it would be most interesting probably to have 3 separate outcomes. I think this is really one of those decisions that you'll make. Like you could have one that is, one run chart that is this woman is positive for any one of the 3. But then it would sort of lose some of its appeal that way, right? Because you wouldn't know what they're positive for, and you wouldn't know if they're positive for polysubstance abuse.
Right.
So I think having 3 of them would be awesome. Having 4 of them would be the best, maybe, because then you'd be able to see 15% of the women that we screened were positive for something, and 5% were positive for drugs and 5% for alcohol or whatever. But that's something that I think those are real personal decisions that you kind of have to think through what's going to help you best.
And when I looked at my patient tracer, I did break it down like that. So I did look at alcohol, specifically tobacco, and drug use all separately. So I did, my thought was when I looked at the outcomes, I was going to look at all 3 of those separately. When I think of, when I see the charts, I always kind of, get tunnel vision into one and trying to keep it brief. So I just didn't know. So I would break those outcomes into 3 different areas.
Yeah, you can do it as a composite where you combine all of those things into one, but list them separately. So I know you're not even trying to think about run charts down the line, but if you had to, you'd have each individual one and then the big combined one, all for that one ramp. And I have a student right now who's doing that for one of hers. Her actual C ramp is a composite, and it works.
Yeah, that's awesome. I mean, that'll make for some really cool data when you go to present this or go to write this up at the end. It'll be nice to have all of that. Will you tell us a little bit about what you're going to do with positive screens? Because I would imagine that's your D ramp. We haven't really had anybody talk to us about referral and treatment.
So that's going to be the referral and treatment part. And I'm still trying to hammer down so I work in a large academic practice, and we have many different departments. However, our psychiatry department is not willing or does not have the ability to accept our patients that need referral, which has been, even for postpartum depression and trying to get our moms in quickly to some place that they can receive stabilization has been very, very difficult for us. So that is probably my hardest job, is trying to find places that we can refer our patients to for treatment. I've gotten the information for the director of the local community service board to see if that's an option for referral and creating a better process for the department to be able to refer those patients to. So ultimately, for the process 2 in the D ramp is going to be an intervention that either allows us to provide treatment. So for those smoking patients, sometimes we will use the Nicorette gum in those patients. So it would be treatment for those patients, or referral to for treatment to the local CSB, and with the hope of being able to find some collaboration with our psychiatry department so that we can get those patients, since it is within our system.
Does your system currently have a way to track the people? Because I think that everybody kind of gets caught up in, because it's SBIRT and it says referral, everybody gets caught up in the actual referral. So if a referral, honestly, I think that for busy systems, referral could be your whole project for some people.
Yeah.
So if you try to think out of the box and think, do we even have a system in place to track these things, or some kind of tracking log? If you're unable to refer after you talk to this person, that's kind of where I'd change my thinking. So just kind of think about it in the back of your mind, that just because it's called referral to treatment does not necessarily mean that you're referring somebody out. You're doing whatever you can to make sure that they're getting the proper follow-up that they need.
And I think that that is probably going to be the easier, and I hate to use easier, but the more efficient way of doing it, just because in the time frame that I have to do this is really not going to be feasible, I'm thinking, to be able to get those systems on board and create collaboration with them. So having a set guideline or protocol in the clinic for follow-up in those patients that screen positive, we do this, we call this person, we schedule with this person, and bring that patient back and forth, in 2 weeks or in a week, to make sure that they're stabilized and able to, or we walk that patient over to the ED in those cases that they need immediate treatment. So I was still working on that DRAMP, just because, trying to work through whether or not, I'm going to be able to refer is something, that, and I have like notes all over, CSB referral, question mark, because it's like, and, trying to find the people to be able to contact to see if it's even possible. But the other thing is that, even like I live in Norfolk, Virginia, and even if I call Norfolk CSB, if that patient lives in Chesapeake, then that patient can only go to Chesapeake for treatment and management. So you wind up working with, 5 different CSBs in 5 different cities trying to get them referred. So that was the other area that I was trying to work out and see if that was even possible, but I don't know if it'll be possible in 8 weeks.
Yeah, my advice to you would just be to get on that as fast as you can and try to make that plan. Like, whether you create an algorithm that just says you contact this person or whatever it is, whatever you're going to do for the project, try to nail it down as fast as you can.
Right.
Does anybody have any other questions about those 4 ramps, the A, B, C, and D ramps?
Yeah, I do. So
Great.
I guess, let me see if I can show you kind of what I emailed it to my other computer here so I can show you them. So I'm not sure if this is where I'm supposed to be going with this. So of course with my C ramp, I don't know if you can see that now. It's, basically for my C ramp is to improve documentation, since that was such a big problem. And then, of course, my implementation for that was, implementing dot phrases within Epic for tobacco counseling. And basically, part of that was educating the clinicians on basically using the template and the dot phrase that's going to be put into the system, which I already have one developed, and then they're putting one into, our Epic system so everybody can just use it when they put in dot smoke cessation. And then, of course, for my second process ramp, of course, is going more to more treatment offered or referral for treatment given. And then basically the implementation of basically the, our guidelines, of course, but I'm just not sure exactly about, the D ramp, if that's the right direction to be going with this, or how I should be doing this.
Yeah, so your DRAMP, I think, makes a lot of sense to me because you don't know whether your clinicians will be prescribing or whether they will be referring out.
Yeah.
I'm just trying to look at what the, so what is the process versus the out? So the process, I'm sorry, I'm getting a bit of an echo. Let me see. Will everybody mute who can? Yeah, cool. And then Dirk, will you bring your, yeah, thank you. Bring it back up. Okay, so so your process is supposed to be the thing that you do that drives your outcome, right? That is the thing that you want to happen. And then all of your outcomes together are the thing that lead to your aim. So it's sort of this like building blocks, right? The processes are the things you do to get to the things that you want, and all the things you want together will lead to the thing you really wanted, the big goal, the aim. So when I read your process here on the DRAMP, the implementation of tobacco cessation guidelines in urgent care through provider education, resource available in clinician work areas, and then you'll have the state telephone quit line contact handout and provider resources for treatment options. It's kind of a lot of different things. It's a lot of different ramps sort of all together. And I think this is kind of what we talked about earlier when we talked about your staff engagement, right? There was kind of a lot of ramps like together. So what I want you to think about are what are those processes? So what are the tobacco cessation guidelines? Do you want all the providers to implement the tobacco cessation guidelines? And I don't actually know them off the top of my head, which is what makes teaching in this class so interesting because you know this project way better than I do. So so I'm assuming that these are going to be like some algorithms probably. They're going to be something that you're going to want everybody to follow. So then your process might be that the provider follows the algorithms. And then your outcome is that the treatment, the patient has either been treated or referred or something like that. Tell me, is that kind of what you're thinking? Does that sound right to you?
Yes, I mean, you know, a lot of it is just, you know what I'm saying, you know, I guess a lot of this is how it's going to be verified is basically that in the charting, which goes back to documentation, which they start overlapping each other, is that they're charting basically, yeah, the patient was referred, or basically, you know, appointment set up with the primary care, or that basically, you know, saying, you know, patient, you know, is going to come back even to urgent care to see them, you know, I'm saying in a week from now. So, you know, a lot of it's just trying to bring them all together, but they kind of, you know, I'm saying, like I said, they're intersecting everywhere. That's what I'm finding, unfortunately. So
they do
having that variation.
Yeah, so. In real life, these things really, really do intersect quite a bit. But what I want you to think about is the different ways. Oh, hold on. Okay, what I want you to think about are the different ways that that your project kind of gets organized, so that you're intersecting as little as possible. Things will sort of want to bleed together, but you're going to try to keep them in their boxes. And I think you're on the right track. I would just really focus on the process being that providers are going to implement those algorithms, and then the referral, that your outcome is that you're going to be following them up and referring them in some way, and kind of think through it that way and see how you end up. So the thing we haven't talked about yet, there's two things we haven't talked about yet, actually. The first one is balancing measures. A lot of the time, this really, really throws people. So I will tell you my favorite way to think about a balancing measure. And there are lots of ways to do it. But I think the most effective balancing measures are the ones that disprove your critics, right? Because there are going to be a fair number of people who are like, oh my gosh, that Lizzie, she's always asking us to do something more. She always wants more, and we don't have time for this. It'll be something like that, right? There will be some people hanging out in the break room who are saying, you know, that questionnaire is too long. There's no way I can answer that on every patient or whatever. And so you need to think about what are your critics going to say? That nurse that is never happy with anything, what is her concern going to be about this project? And my recommendation is that your balancing measure really address that thing. So if the concern is going to be like in urgent care for Dirk, I can promise that that the providers are going to say, we do not have time for this. Like, this is not even what urgent care is for, right? And what you're going to have to do is make the case to them yeah, you know what, you do have time for this. And so part of the way you're going to do that is by tracking how much extra time do patients actually take or something like that. And you want to pick something that's actually measurable. So your EHR might have a way of tracking the amount of time the provider is actually in with the patient or something like that. And if it has the capability, well, then that's perfect. That's what you should track. Because then when somebody says, oh, well, because of Dirk, now I'm here for 1 million hours every week, you know, then you can, and you can be the one to say like, hey, I actually tracked that. And you know what? The average increase in length of time with the patient was 60 seconds. So I don't know what you're doing, but it's not me. So think about those kinds of things with your project and see if there's something like that. If none of that kind of stuff really works out, then the balancing measure you can sort of always fall back to is you, right? Because these projects are going to work, and they're going to work because you are a committed and energized champion who is spending a lot of hours pouring into this project. Would this project work if you weren't committed to putting lots of hours into it? No. It probably wouldn't, right? And so that's worth tracking, isn't it? It's worth thinking about how many hours a week did you really put into this project to make it work? And I think that's helpful to show a healthcare system. Like, hey, we really did the right thing here with postpartum hemorrhage, but it took me 20 hours a week to do it. And you don't pay me for those 20 hours a week. And now I'm at the end of my 10-week or 8-week implementation, and I'm not doing it anymore. So I think that's important information for healthcare systems, that this is the amount of time it takes to really implement quality improvement. What are the balancing measures that you are already thinking of or that you wanted to do?
I was thinking about possibly looking at the amount of time or the number of times that nurses have to stay after their shifts to document. Because I feel like that's going to be one of their things that they're going to complain about is I had to stay late every shift I worked last week.
Yeah, it's possible that it will make a big difference. Is there one triage nurse at your facility, or is triage split among all of the nurses?
So during the day we have 5 nurses scheduled, and at night we have 4 nurses scheduled. They always stick 2 nurses in triage and 2 to 3 nurses in the, we say in the back with the labor and patients.
Okay.
And then,
so what I would recommend doing is maybe just tracking the triage nurses then, if you're, well, I guess actually now that I think about it, no, your project includes everybody. So
yeah, and the triage nurses are not always the same either. Just like the labor nurses aren't always the same. We move back and forth between the 2 areas.
Mm-hmm. Okay. So tracking length of time that people stayed over their shift. So what you would need for that to be able to prove that your project wasn't creating a super long length. Why am I telling you the answer? You tell me what you would need for that.
I would need to know how often nurses are staying late now before we're doing that, and then compare it with how often they're staying late once we start implementing.
Yeah, perfect. So you need some really some good baseline data. We didn't really talk about that, or I didn't mention it, but pretty much all of your measures should have some baseline data, and you should be collecting that right now. So think about how many patients are having their smoking status addressed right now, and how many patients are having their risk factors for postpartum hemorrhage addressed right now. Those kinds of things. Anything you can get baseline data on, you should collect it all right now. What about other balancing measures? Anybody have anything interesting they want to share?
I was thinking about how long it takes for our medical assistants to get the history now and after the addition of the screening questions. If there's a difference between the time that it takes them to get the histories and prior to adding those questions and then after. To see, because that's what we're going to get. We're already asking all this information. These patients are high risk, and now we have to add more questions to that to assess their high risk. So that's one that I was thinking about.
Yeah, is there an easy way to measure that in your facility?
So we have trackers on when they're not really trackers, but whenever the patient switches from like one process, so from registration ready to nurse ready to provider ready, we can see the times up in our Allscripts. So starting with when the patient becomes nurse ready, looking at that time, and then documenting from nurse ready to provider ready. So before, which I've already looked at when I was doing the patient tracer, to afterwards with the addition of those questions.
Awesome. Yeah, that's perfect, especially if there's an easy way in your EHR to just run a query on all of the patients, all of your OB patients, or whichever, however you're doing this. So.
Right.
I might need you to ask you how to do that.
Say that again.
I said I might email you to ask you how to do that, because we run all this as
well. Okay.
So, great idea. Thank you.
Yeah.
Man, Epic is really popular. I think everybody in this group almost uses Epic.
So you're on Allscripts?
I'm on Allscripts. We do use Epic as well. But we use it, it's our hospital system. So we have one system for the office and one system for the hospital. Makes life crazy, but.
Okay, so cool. I think you guys have balancing measures down. So let's talk a little bit about data collection. One of the hardest things I think is when you walk into the clinic or walk into the setting, wherever it is that you're going to be doing your project. You walk in the first day and you sort of look around like cool, glad we're starting. What am I doing? Like, it's hard to know how to get started. What are you supposed to do first thing? You pull those charts, and what were you looking for? So I know you guys in some of your assignments already have had to create a spreadsheet and use a data collection form. Have you created data collection forms for your measures yet? Do you know what those are going to look like? And let's talk about operationalizing measures. All of that. Does anybody have any questions straight off?
I think they might be overwhelmed.
Okay, that was a lot. You are kind of the run chart guru, at least in my mind. I've actually never made them, other than I'm making some now. I'm running some projects now, and I'm using them. But up until now, I have not used them.
So you need to develop. Number one, when she says data collection tool, I highly encourage everybody to learn Excel. Like, you need to learn Excel right now, this term, because if you try to learn it next term, it's gonna overwhelm you, because the first thing that we ask you to do next term is to set up run charts. There is a template that's provided in IHI. I never use their template. Like, my brain hated their template. I created everything from scratch because it just made more sense in my mind. So if you're one of those people who like Excel and like solving problems and getting stuff done, then that's always an option. But try to get your data collection tools. Don't have 5 million sheets of paper. That is going to keep you highly unorganized. Remember, paper gets lost. Okay, your computer can die, but if you back it up on a jump drive that you take everywhere with you and guard it with your life, you'll be fine. Your data is so important, because you're going to use all of that to place on a run chart, and your run chart is what you're going to analyze to see, are my interventions working? Are all these tests of change that I've done, are they actually working with this? So it's so important that you get yourself organized right now. What else did you want me to talk about with the run charts?
Have you guys seen a spreadsheet that anyone is using to collect all their data? I don't actually have one here.
I might have one. Hold on.
So what's important to me is that when you're collecting your data, that you don't have to think that hard while you're actually collecting it. Like, you're going through the charts, right? And you're looking for your data, and it's like you're entering it into your spreadsheet. So you're like, yes, they had the postpartum hemorrhage screening completed. They scored this. They all the pieces of information that you need, and you're just typing it down the row because you already know how you're going to compile that data and what you're going to do with it.
Is it going to look like our audit tool?
Maybe, depending on what your audit tool looks like.
Maybe I can show mine.
Okay.
Don't wait on me. Sorry. I'll try and find it and get it. I too am on two separate computers.
I think the other thing that we didn't talk about was while she's getting that, is when people need to actually write your aim on your measurement worksheet and know what your aim is. For most people, you're not going to come up with your aim until you've come up with what exactly you want to do. Once you have all those pieces, then you're going to go back and write that aim statement so that it encompasses every single thing that you're trying to do. What's your big overarching goal of your project? That is going to be your aim statement, but you don't know that until you narrow down what you're going to do for each specific grant.
Okay.
And remember to answer those 3 questions.
All right, so I don't know how I do this, but you said I go to the
Left side of your screen,
left side of my
white
screen.
arrow with a green box.
Okay, so maybe I just move this out the way. Don't mind all my things.
Yes.
Okay, so that's what I use for my tool. Would that be sufficient for collecting my data?
Yeah, something like this is what I was talking about for your data collection. Some people use it and do it in just a straight up Excel. And I can't tell, it looks like maybe this is in more of like a Word doc type.
No, this is Excel.
Oh, is it? Okay, I'm sorry, I can't see. Okay, yeah, I think something like that would be great. So this is how you would do all your data collection, and then you would actually add it to the run chart, and the run chart would create like a graph for you.
And
yep, at the bottom where you have your yeses and nos. Yes, perfect.
So
excited.
So that's how I did it. And I like Excel. So these are all formulas that are already populated in there. Okay. I just wanted to see if that was okay.
No, that's really good. That's perfect.
Okay.
The more you know formulas, the better off you are, because then you don't have to calculate everything by hand.
Okay.
Because I have some people who are using Excel, but they still do the calculations manually. And I'm like, if you just enter the formula, it does it for you.
Mm-hmm.
So back to measures and operationalizing them. Dr. Meyer asked if anybody had questions. Everybody knows how to operationalize their measures.
That's basically creating, saying the number of screens, or the percentage of screens that you are gonna, or whatever your processes, and making that putting a numerical value to that, whether that's a percentage or a number. Correct.
Yes, putting them in numerator over denominator format.
Yeah, and this is real important because you don't want to have to think about this later on. You want to just already know. You want to know that, because it can get confusing when you're thinking about it in the moment, and you don't want to reinvent this every 3 days when you're doing data collection. Because that's what will happen, where you'll do it one way on Monday, and then on Wednesday you'll think you're doing it the same way, but then you just won't really realize that you're doing it differently. So if you are screening everyone, then you want to know how you're going to do that. What is your numerator and what is your denominator? So if I were screening everyone, my numerator would be the number of people that got screened, and my denominator would be the number of people that showed up in the clinic. That would be how I would do that. So if I'm doing data collection on Monday, Wednesday, and Friday, then I think I would want to look on Wednesdays. I'd want to look back at all of the people that came in on Tuesday and on Wednesday, so that I was catching all of the charts, and I'd want to look at how many people were screened and how many people showed up. And then that's what would create that percent. That numerator and denominator creates a fraction for us. And that's how we know what the fraction of people that got the thing we wanted, which was the screen everyone. That's how we would know that. What can confuse people sometimes is, is the denominator just the people who came in on Wednesday? Is the denominator just my patients? Is those kinds of things where you really want to be consistent and you want to know what it is that you're doing, what your plan is. Does anybody have questions about that? Like, feel like you're not quite sure what your numerator and denominator would be on your measure?
I'd like to talk about it a little bit for mine. So I kind of reworded my anemia outcome measure, and then I changed it to say increase the number of patients with anemia that have a viable plan, like diet changes or plan to take their supplement to combat their anemia. And then my numerator for that would be like number of patients with a plan, but over the number of patients with anemia that present to triage. Okay.
Yeah, that's how I would do that. Perfect.
Okay.
And over what time frame? And we don't really request that you write this down, but I just want you to know for yourself, like, are you pulling all the charts from Wednesday? Are you looking at all the charts from Tuesday and Wednesday? And in your case, I would tell you, make a plan so that you're reviewing data about 3 times a week and that you're catching all of the charts for the whole week, everyone who came into triage, because there may be less anemic people coming into triage than you think. And I know that's what you're going to look at in your baseline data tomorrow. That's what you're already going there to find out. It's like how many people are presenting to triage and how many of them are anemic, because we don't want to get in that ugly situation where we can't do our stuff because nobody's showing up.
Right.
So you guys are all rock stars. You've all got this down. Exactly what you're doing. Or you're so lost you can't quite even share it yet.
I'll tell you what. I've been weeks. So thinking probably bi-weekly.
All right. Cara, do you have anything else that we were supposed to talk about?
No, I think that we've covered everything because I've been checking it off my little list.
I have a quick question.
Covered everything.
Okay.
And
I apologize if it's there's feedback. I tried to use my headphones, but for some reason it won't go in my computer. As far as assignment, Dr. Slager wanted me to ask about one of the. Let's see here. I'm just getting this out. The diagram on one of the criteria, it says include teamwork, patient engagement, and process tools. So is that something that, because I've filled out my diagram and I feel comfortable with all that, and from that I've been using things for my ramps and everything, but do we need to include our teamwork engagement and patient engagement and all our process tools and checklists and everything like that in this project as well? Or is that something I should talk to Dr. Jolly's about real quick?
So are you talking about using it when you turn in your charter? Is that what you're referring to?
No, turn it in.
Okay, so you're talking about for your cause and effect diagram.
Right. Yep.
So for your cause and effect diagram, you don't have to turn any of those tools in. Basically, you're looking at the gap and working the way that you're working. You will, though, like, don't not work on those tools, because you will need them when you go to submit the first draft of your charter. You're going to have to, whatever tools you came up with for patient engagement, team engagement, if you're doing an algorithm, you're going to need to have that. So you're going to need to have all of that. If you're giving patients handouts, you need all of that to submit with that charter.
Okay, that was just my question, was to make sure that with the cause and effect.
Well, I don't know. It feels really wrong to be done 16 minutes early, but maybe you guys will get over it. I don't know. All right, I'm excited about your projects. I think you guys have overall a pretty good handle on things. Work on your measures worksheets. Get your measures worksheets really, really down so that you know exactly what your processes are, your outcomes are, how they relate to your aim. All of that stuff. You just really want it, you want it solid. You want a way to operationalize it so you know exactly what data you're collecting and exactly how it's going to go on your run chart. You just want there to be no questions at all. When you enter next term, I want you to feel like all the things that could be nailed down are, so that then the chaos and ambiguity that come with implementation at least is not compounded by lack of preparedness.
Just one last question, because I think Dirk and I are doing similar topics, and just like him, I think about all the things that I want to put in that, these process boxes and the process measure boxes. For these measures, we're only doing or putting in one thing, correct? Like, we're not adding multiple, because that was my thought too. That I was going to put all these things in for my screening. And I think it's just a natural kind of reflex to do that because they all are inclusive. So just focusing on one tool, one process measure, one operational definition, one outcome measure for these sheets that we're submitting.
Sometimes you will have more than one process and more than one outcome. I just really want each measure to just be itself, though. So if you are talking about screening everyone, I want your measure to be about screening everyone. Okay. The things that you do to motivate the staff to screen everyone, those things are staff engagement. The things that you do, I just want you to really focus on that one measure. And okay. It may end up that you have more than one outcome for that measure, or that you do more than one thing to make that measure happen. But it shouldn't be, sort of a bunch of things from different ramps thrown in together, if that makes sense.
Yes. Mm-hmm. Yeah. Thank you.
Sometimes this stuff is hard to figure out. It is not as straightforward as it seems. And it just requires, the only way I can describe it is just a lot of hours of thinking. And I feel like that's the thing that's misleading about this class. You look at the assignments and you think, oh, like that assignment doesn't take me that long to write. And it doesn't take you very long to write it. But how many hours does it take you to think about it before you write it? And that's usually what is harder. And it's the part that, as much as, Cara and I have done these kinds of projects in the past and enjoy implementing things, it's the part that we can't really do for you. I get sometimes caught up in trying, so stop me if you ever see me doing that. But that's not how it should be, right? I mean, you're the one who spent all of those hours on your literature review, and you're the one who has walked around thinking about this project night and day. The answers are probably somewhere inside your head. And I just, have seen more of the pitfalls and can hopefully guide you away from them or help you to find the right structure. But the most important thing is that you develop a really great project, and you are the only one who's going to do that. All right, I am impressed with you guys. I think you're on the right track. If you need more help, do not be afraid to reach out. Talk to your continuity faculty, get more help. Spend all those hours thinking, pacing, whatever. Figure it out. Figure it out.
Go back and watch some of these other buzz sessions. If you're still stuck, you can always look and go lurk in, I think there's another buzz session. So if you're still stuck,
Wednesday morning.
There you go. You can go and lurk. Like, you can't really ask a million questions because there are going to be people there who haven't had their first buzz session, but you can hear this over and over. So, and I think that's what a lot of this is. You have to hear it over and over because it's like learning a different language.
Yeah, I would totally agree with that.
How do we find the videos, like to the bus? Like, where are they?
So the screen that you signed up on, like that has your name, the screen that has, hold on, I think I've got it right here.
You go to the modules, and then where it said under module, sign up here in the course, you click on that, and that's the spreadsheet. And remember, it has those 3 tabs where you have to sign up on each one. We post the videos in there.
Oh.
We put a link.
Okay.
Yeah, so you can go back and watch any of the sessions.
Okay.
And that applies to later on, too, in all the classes, whenever we do these reverse classroom things.
I did not know that.
Yeah, they're always there. They're easy to find, and you don't have to, nobody can see you. So it sounds like it'd be so cumbersome, right, to go watch 8 hours worth of classes. But you can be doing all kinds of other things. Every time you make dinner from now on, just put on a buzz session and watch it while you're making dinner. You can listen to them while you are walking. You can, this is how, I do this all the time. Like every minute can be useful. Go ahead and let it be. All right. Well, if you guys come up with other questions, you know all your resources. You can go look for the answers. You can talk to your continuity faculty. We're around, but I think you're on the right track. So just keep it up.
Thank you.
All right. Thanks for coming tonight. I enjoyed it. Can't wait to see your projects and steal all your great ideas.
Yep.
All right. Bye, guys.
All right, bye.
Good night.
Bye.
Dr. Meyer, can I ask you a couple of questions? Dr. Jefferson, too, if you're available still. So, sorry, I'm getting an echo too. Are you hearing that?
Here, let me mute just in case it's me.
Do you want to be recorded, or you want us to stop recording?
We can stop the recording.